over a 20-year period. Now you think that those clubs can go without explaining to their membership what
I'm not sure who's got some
Yeah.
background on.
Is that Vanna? Oh, there we
I'm not sure.
Where do you fit in?
Seems like everybody's got their mic off. But
Oh, where does the Department of Agriculture stop? I would assume you're gonna dump it on there. Oh.
So welcome everyone. If you haven't already, please put your name, add your name and organization to the chat. That would be great. Thanks. Also, we sent out the minutes at the last meeting, from the last meeting early this morning for your review, and the agenda for today. Great.
Well, good
Welcome.
morning, guys. Joining from the car, but I'm here. Hi.
Hi, Veronica. Hi, V.
Hi.
Thanks for joining.
Of course. I'm here in the background if you need anything, Tim, any technical needs. You need to make me
Appreciate it.
co-host.
Appreciate it. Yeah. Thank you. Okay. Well, we'll get started. Welcome everyone to the Westside Heroin Opioid Task Force Housing Work Group meeting, April 8th. It's just great to have everyone here. I sent the agenda out early this morning along with minutes from the last meeting we had in late February. If there's anyone who didn't receive the minutes, please let me know, and I'll work to get those to you as we move forward. So if there are any comments too on the minutes or anything that people would like clarified or added to or whatever, we'll be happy to do that as well, or clarify or change even if there's an incorrect, something that needs to be corrected. Please let me know. But I wanted to ask if there's anybody that hasn't been part of this work group before, is joining for the first time or hasn't joined in a while. If you could just take a minute and introduce yourself and where you work and where you're from, that would be great.
Good morning, Tim. Good morning, everyone. My name is Jim Eaglin. I'm from Maryville Academy's Recovery Home Network. We have 2 recovery homes. This is my first meeting, and I'm honored to have been invited by Mary Dowling. But we have 2 recovery homes, one in Westtown and one in Austin. There's a lot to say about that, but mostly what we do is we provide recovery housing for people post residential treatment for a period of 6 to 9 months in each recovery home. So if you were a mom with a child that needed housing and was on the other side of recovery, into recovery, on the other side of residential treatment, I should say, we would be something that we would like to be considered. And of course, regarding housing, we're always looking for places for people to safely discharge to after they're done with our, with our service. So it's really nice to be part of this. Thank you guys very much for inviting me and welcoming me. It's good to see you guys.
Great, Jim. Welcome. Thanks for joining. Anyone else?
Hi, Tim. I'm Peter Gubby. I'm with Task. I've been, I think, at 1 or 2 of these meetings, more sporadic over, give or take, going back to probably a little less than a year now.
Great. Great to have you, Peter. Thank you for joining. Okay. Well, we'll have some time for updates from all of us and organizational or program updates. as far as further discussion about the topics that we're going to have today. But to kick it off, we've invited SUPR to come in and present to us, or to be part of a discussion with us about admission criteria for moving into recovery homes. We've had a couple of prior work groups give attention to specific meetings given to the recovery home experience for people, and the Cook County, I hope I'm saying it right, the Collaboration Network or Navigation Network presented a few months ago as well. Last month, Advocates for Human Potential shared an update to a map that they're working on that will allow for all of us, really, to including clients and people we serve, to be able to go into use the map to identify where the recovery homes on the west side are, addresses, admission criteria, this group's specific ineligible criteria too. It was we're working to get more of that listed as well. But there's from that discussion came additional discussion about recovery homes and what all is required for moving in, specific to issues of sobriety, abstinence, and so we invited SUPR to attend, and we have Emily Piper with us this morning from SUPR, who's been with SUPR we just learned for a few months now. But anyway, Emily, I'm going to let you introduce yourself, and we're all here to kind of just learn and talk through a little bit about the rule, and appreciate you being here. Thanks.
Thank you. Thank you. I hope to learn from you as well. My name's Emily Piper, as Tim mentioned, and I am the statewide residential recovery services coordinator for SUPR. Like he said, I've been here since December, so give me a little bit of grace, but I've seen a lot of you in different meetings, so I'm warming up to everyone, so it's kind of nice to see familiar faces. Tim had asked me to provide some interpretive guidance on Rule 2060, and how it relates to the recovery home admission with I'm sorry, I'm blanking out already, but let me bring up the slideshow to help myself.
Oh, great.
Can I share my screen on this presentation?
Can we do that, Fania?
Do I get to do that?
We'll just need to get Emily over credentials. Fanya, is that something you can do? Because I don't believe I'm co-host on this call.
Am I co-host?
There you go, Emily. I think Fanya's working it out, working the
Okay.
magic.
Yeah.
Okay, cool.
You should be able to share shortly.
Okay. Oh, there it is. Okay, let's see if I have the multiple. Let's see if okay, I think I have the ability here. No. I have like 3 screens going, so give me
Take your time.
to make sure I get the right one. Okay. Okay. Got that. Do you guys see something called Zoom?
We do. We see your screens coming along.
Okay, cool. Okay.
There you go.
Okay, got it. So, basically, so I was going to provide some guidance with Rule 2060 and how it relates to medication-assisted recovery and substance use in the homes. It seems like there's been a little bit of discrepancies, questions on if people are allowed to be admitted into homes if they are using substances, or if they have, or if there's a slip, or how all that works out. So, first of all, recovery homes in Illinois, they have to follow Rule 2060.509, which I'm sure most of you are aware of. And then in addition to that, if you are funded, you need to follow the contractual policy manual as well, which both of those are on our website. So let's look at what Rule 2060 is to start. Let's see. So Rule 2060 says, recovery homes are alcohol and drug-free housing components whose rules peer-led groups, staff activities, and/or other structured operations are directed towards maintenance of sobriety for persons who exhibit treatment resistance, relapse potential, and/or lack of suitable recovery living environments, or who recently have completed substance abuse treatment services, or who may be receiving such treatment services at another licensed facility. In order to be called a recovery home, the recovery home shall provide a structured alcohol and drug-free environment for congregate living that shall offer regularly scheduled peer-led or community gathering. Self-help groups that are held a minimum of 5 days per week and provide recovery education groups weekly. So what does this mean for your recovery home? Let's break it down a little bit. So the first line says recovery homes are alcohol and drug-free housing components. What we mean by this is that a resident cannot use in the facility. This does not mean that a resident cannot has to test negative prior to entering the facility. It just means that they are not sitting in the recovery home using substances and or alcohol. Okay. So if they cannot use in the facility, and then they have peer groups, staff activities, and or other structured operations that are directed towards maintenance of sobriety. This means that substance use does not require automatic discharge. We are working towards helping them maintain their sobriety. This means meeting them where they are at. There is no time frame to determine what sobriety is or isn't. That's going to be up to the individual homes. The homes are going to establish policies and procedures to determine their own individual practices for their home. Okay, and if we go down to part A, provide a structured alcohol and drug-free environment. I think that is a lot of times what's happening, what people read that causes them to, panic or think, oh, we can't have someone in the home that has tested, that may have drugs in their system or may have had a slip that they have to leave. That is not the case. It just means that a person, once again, cannot use in the facility. Okay, so for our funded recovery homes, we have, in addition to Rule 2060, we have the contract policy manual. I think it's like B of that. Under the recovery home specific language, it says the organization shall ensure that all individuals receiving recovery home services are sufficiently stable and are actively seeking assistance in obtaining or help maintaining an illicit drug and alcohol-free lifestyle. So what do we mean by that? Sufficiently stable. So SUPR does not define sufficiently stable. That's going to be up to the individual home. Individual homes, they're going to have their own policies and procedures based on their staff capacity, based on their home and how they want to operate their home. That's going to determine what sufficiently stable means. Seeking assistance in obtaining or help maintaining an illicit drug and alcohol-free lifestyle. Once again, there's no time frame in obtaining an illicit drug and alcohol-free lifestyle. There is no 3-day rule. There's rumors that there's like a 3-day rule that you have to test, be sober for 3 days prior to entering the home. That is not the case. SUPR does not determine that. So basically, to sum it up, a negative test is not required for admission into a recovery home. Recovery homes, they establish their own policies and procedures. Contrary to belief, providing a drug-free environment means not using in the home. That doesn't mean if you slip that you're not allowed to be in the home. That's going to be up to the individual homes to determine. Substance use does not require automatic discharge. That's a big one. Substance use does not require automatic discharge. You do have to have policies and procedures in place to determine, to lay out what you're going to do if there is a slip, or how you're going to determine, how you're going to move forward with it. But SUPR does not determine that. SUPR does support medication-assisted recovery in homes, but we also know that there's multiple pathways to recovery. So, different processes work for different people. Some people are going to want the medicated assisted recovery. Others are going to go like a fully abstinence-based program where no medication is, is allowed. You're going to have to look at your individual needs of the people that you're serving and then lay out, develop your policies and procedures to support that. So that is what SUPR thinks. And that's what I had. What do we think? Does anybody have any questions? Is this what everyone thought, or is it different? What's the consensus?
Hi, Emily. Peter Gubby from Task. I just have one question. Do you find that there's just a need for more clarity among both providers and those of us that are referring to recovery homes themselves? Just in knowing the rules and what those individual, because you mentioned specifically on more than one occasion, each individually licensed facility makes their rules for what they determine, correct, from the rules that are established by SUPR.
Yeah. It seems like it sounds like there was a misconception that homes were not allowing people to be admitted if they tested positive. Under the fear or misconception that maybe SUPR would have a problem with it or it affect their funding or their licensing. But that's on the recovery home, to determine, not SUPR. We require, the outline and policies so that it's clear to the people who may be joining your home. It's clear to SUPR. It's clear to everyone what the policies are going to be. But as long as you have that outlined, you get to run your home the way that you see fit.
I do have another question. I know recovery homes that we've worked in the past have done a very good job as far as medications. And of course, with MAR, it's a medication. So is each individual program required to have appropriate storage for those medications? So the individuals are not storing them in separate apartments for those that are maybe sharing an apartment and things of that nature.
Yes, there are individual storage requirements. I could get you like the exact requirements if I look up on the contract policy manual. And then it's also, I believe it's in the exhibits, like when you're funded. But yeah, there are specific requirements to lay out that they need to be locked up and secure, and that you have a procedure laid out of how they're going to be accessed and when.
Thank you. Thank you very much.
Hi, this is Margarita. I think for me, where individuals get as part of somebody being able to come in and use, like I know for us at Safe Haven, we don't deny nobody because they're positive. All right. What we do work through as stuff is individuals that are going to go through any type of withdrawal because we're not a detox agency. So those are the risks that we look at and stuff. Not that you're positive, but if you're going to go through possible withdrawals, then you'll have to go through detox, then come back into the recovery home. So I think that's the confusion where everybody's saying, hey, they're being denied to go into the recovery home. No, we take people, especially like for us, we're the housing first model. Doesn't matter that you're under the influence, is that we've got to make sure as a risk management, you're not going through any type of withdrawal during the time that, we admit you. So I think that's the confusion everyone is having.
Thank you for that. We've got a question in the inbox from Eva. She says, thank you for this. Is there any plan to formalize policy to allow for more leniency in homes? And is there a limitation on how many days of sobriety are required?
Okay. There is no limitation for sobriety. There's no how many days. That's one important thing. I'm glad you asked. That's going to be up for the individual home to decide. Some homes may put a limit on it, but SUPR does not. And then this first part of your question, leniency in homes. Is there any plan to formalize policy to allow for more leniency in homes? Can you maybe clarify that?
Yeah, sorry. I think the question kind of came out backwards, so I'll try again.
Sorry if I didn't do it any justice, Eva, but please
not at
go
all.
right ahead.
Not at all. I tend to be a wordy writer, so it's on me.
No worries.
So I appreciate that this is definitely up to each individual facility, and I understand that. And I do also understand that it's not a written policy by SUPR, but I have found that sometimes because of the lack of verbiage in policy, that can be an inhibiting factor to people getting into homes. So I'm just wondering if there's any plan to kind of formalize this lack of limitation on days of sobriety or, you know, treatment days or things like that in policy. So to kind of,
Yeah.
yeah, you know
Okay.
what I mean?
Yes. So that's been like a very widely suggested widely suggested idea from people, and I would have to agree with you that the wording could be better. It could be more laid out. 2060 is going under review. It's getting ready to be released for public comment here really soon. I'm not quite sure how it's going to end up, what it's going to say in the end. But we'll all get to see what they're thinking anyway here really soon. And then as far as I know, this summer we're going to work on some learning collaboratives, and just more or less at least putting the information out there, getting it shared wider. So if it's not in writing, as well as we'd all like it to be, at least we can spread the word to help people understand it better. Does that answer your question? Hope?
Yes, thank you.
So I'm curious about what we're seeing, or probably everybody, it's like a rise of just of polysubstance use, right? People who are saying, I need to be sober on this issue, but on another issue I can't, right? And how can recovery homes or SUPR or something help with this issue regarding, like, total sobriety from all drugs, or like maybe a harm reduction modeling of housing? So yeah.
So I know that we at SUPR, there's a lot of talk about the harm reduction models, and I don't personally feel comfortable commenting on it right now, but I do know that what you're asking is like a fair question. I think SUPR overall is we're here to help. So as far as meeting people where they're at, that's a common thing that we talk about internally, that not everyone wants to be, completely sober of everything. Maybe we want to improve our usage, like improve what we're using. Maybe we don't want to be completely free of drugs and alcohol. And as far as like a recovery home, we've been talking about different ways to define it, and which is crazy because we're already talking about like additional changes when the last changes aren't even released yet, and we're already past that, like looking at the future. Maybe in the future we could it's kind of like my thought process personally would be to look at additional housing options, maybe that aren't called a recovery home, because in the definition of Rule 2060, there is no usage in the house. There's no, it is what it is, and we can't change the law as easily as we could potentially create other alternatives for people to help them as well. So.
Thanks for that. I think we have a question from Chicago Recovery Alliance. Did you want to hop on and ask yourself? I'm not sure who's that from Chicago Recovery. John Warning, is that you? All right, I'll ask on their behalf. The question is, for Safe Haven, are spots earmarked for those folks that come to Safe Haven but have to first go through med stabilization?
Through Safe Haven?
Yes.
No one, like I said, we take individuals who are currently, maybe under the influence, as long as they're not going to go through withdrawals. Anybody that's on any type of medication and stuff, they necessarily don't need to come in for their medications, with the exception of a couple of them. Whether it be something like if it's seizures, we can't have somebody on site with seizures and then they have a seizure and they didn't have their medication. So those, what we do is for those immediate medications that they may need, all we do is refer them over to the nearest emergency room to give them the temporary medications that they may need while they work with their primary doctor to make it more stable. So no, they don't need to necessarily have their medications unless it's a, you know, insulin or something that's going to be life threatening, you know, due to the risk management. But doesn't mean they're denied entry that day. Just means that they need to get a medical clearance. With that,
I'm so
mhm.
sorry to cut you off. They just clarified their question. Someone from CRA probably can't join us audio, but they said medical stabilization, not medication. So the question is, are spots earmarked for those folks that come to Safe Haven? Would have to first go through medical
But
stabilization.
we don't do medical stabilization. So if you're talking about, and I just want to make sure we're clear, we don't do medical stabilization for individuals who may possibly going through any type of withdrawal in our recovery home. So we're not a detox facility. We're not licensed for detox. We're only licensed for our recovery homes and level 1, 2, and residential. So no detox. So if you're talking about that medical stabilization there, then no, we're not licensed to do that.
Okay. I think the follow-up question was exactly what you answered. Are they earmarked while the person goes through detox? I think you just handled that answer. Thank you so much.
Mhm.
Nothing currently else in the chat box if you guys want to move forward.
Hi, it's Sammy. Can I just say something quickly? This is, I guess, not so much a question, but maybe just some feedback about things that we've talked about before in this working group.
Absolutely.
I know we've talked a little bit about some of those like very medically complex patients or clients who kind of just fall through some of the gaps in terms of being able to access any type of like residential or recovery homes. And like some folks that we've talked about in the past, like kind of like categories of people are like those with like complex medical conditions like wounds or things like that, where even like residential treatment programs, inpatient treatment programs don't feel comfortable medically managing that. Or clients with certain like offender status or sexual offense backgrounds. I know there was another person in a previous meeting who brought that population up. And so I guess, Emily, this is maybe more feedback as you kind of talked about, like perhaps a priority for the future of SUPR is thinking not necessarily about how those folks get integrated into recovery homes, but like what type of housing is appropriate or more harm reduction focus that can focus on housing them. But I think we see sometimes those like the traditional pipeline of like getting somebody connected to inpatient treatment for 28 days or to detox. And then from there, getting them connected to a recovery home, like doesn't quite work because there's so many complex factors, but they're unhoused and they're interested in using less or like moving into recovery. And so we run into a lot of barriers as like service providers, like trying to find the right places to connect them. So I just kind of wanted to recap that because we've talked about that at past meetings too.
Yeah, I appreciate that. That's another thing that comes up. I'm not sure if you're familiar with James with our team, but he's a big proponent of that. So we that comes up too.
Do you know, Emily, if there are some projects in the works that will, you know, provide these pathways, you know, housing support, I guess, type programs, where, you know, more of the social determinants of health and you know, wraparound support, I guess, kind of care is provided, not so much as much an emphasis on, you know, the daily support group, the 12-step meeting, and the, you know, the structure that's provided in a recovery home, but more of the wraparound support, linkage to healthcare, linkage to whatever it is the person needs that will help them take steps forward.
Yeah, we have there's a lot going on internally. Since I am newer, it's hard to say like how close we are to like implementing it. But we do have lots of work groups that we go that, I mean, our team of, there's one, two, like the 4 main people on our team. They have some big ideas. I'll say the 3 plus me. The
Okay.
3 of them who have been here long, they have some great ideas. And are working towards it. I know that we are doing, I have like a meeting next week where we're gonna start talking about some of the priority populations that do fall through the cracks. So I don't know. There's more to come is all I can say until we, I know that we're just now starting the conversations. At least I'm just now starting the conversations with them. So I'll have to see what next week brings, but it is like everything that's been said here, especially Sammy. That's a common thing. It's been said, yeah.
Got it.
And it's a difficult topic. I mean, it's a difficult answer because everyone, those with complex, either medical needs or like you said, you know, you have someone that's like, with like maybe an arson background. How do we house them? They may need help too, but you know, where how do we support them as they venture through their recovery? And you know, these aren't easy questions, and they're going to take a while to figure out.
Yeah, I think that's one area I know this work group has been discussing and identifying as a need. Of course, we need all the recovery homes that are already providing the care that they're providing, and not necessarily, you know, they're meeting a need. They're housing people, and that's important. That's important to note. It's what more is needed, and the best ways to do that. And for some people, it may be the recovery home model, you know, that's best for them. And it's encouraging to hear your presentation, thinking a lot about the people that are starting on MAR, for example, not necessarily now needing to wait 3 days, you know, or longer, but that is something that could be offered, at least as far as SUPR is concerned. But in addition, then thinking about, you know, other models or other types of housing that are going to be important for folks that may not necessarily be a recovery home, and maybe that's not all what the people want, even, you know.
That's definitely something that we've talked about, you know, because since recovery homes are, you know, governed by Rule 2060, it's really locked down. And it does narrow who it can help, really, or make it a lot more difficult to help some people. So then that's, you know, ways of brainstorming of how can we fix this, and, you know, fix it in a timely manner, if that's even a possibility, like fix it as quickly as possible. How do we do that? And some of the talk has been, okay, maybe it's not recovery housing per se, recovery home, the word itself. Maybe it's a different type of housing along the same lines. Maybe we build out the recovery, residential recovery model to include more than just a recovery home. So hopefully as time, funding and all that allow, we can keep working.
Yeah. Does SUPR have any work groups that are starting or that have already been meeting to address this very topic, you know, building out the residential recovery home model to include, you know, more of the, I guess we'll say, harm reduction type?
Actually, we do. Yeah, we do. We have a recovery residence work group that meets monthly. And that's been a lot of it, is discussing ways, not ways around 2060. It's just how do we help the people that need help when 2060.509 doesn't work for them.
Yeah.
So, yeah. Yeah, and
Emily,
I
I
just
have
want
a
you to bring
question.
back any thoughts that you guys have, or if you can email me, or, you know, any thoughts that you have or anything you'd like me to share with them, I'd definitely do that. Bring it back.
Previously, Emily, I was aware of 2060 offering rule exceptions for exactly this type of specific client when they're targeting them. Is that something that you're considering or in your work group?
Yeah, I think that was, if I recall, the enhanced recovery homes that we were doing for a while. Well, we still are. I don't know quite why, because this was pre me joining SUPR. So off the bat, I don't know quite why it stopped, but there were the two that was for the pregnant and postpartum women and stuff, and so that they allowed some exceptions there. And I had mentioned that just last week, just in passing to Kim, and she she couldn't really, we didn't get into why we haven't expanded it. The only thing I can guess, my best guess would be funding, because that's always the answer, is it's just funding. If we had more money, we would do more. The ideas are endless. The funds are not.
Just as, oh, sorry, I can wait. Sorry to step on you there. I just, in way of feedback, Emily, I just want to say that I for one kind of appreciate the latitude that SUPR gives recovery homes, because I think it's true that there's more than one pathway to recovery, and some people need harm reduction and they need some of the things that's already been mentioned here, and some people need a little bit more structure too. So I for one like it that SUPR allows recovery homes to determine the type of recovery home they want to be. I mean, it's on the rest of us as referral agencies and the part that we do there to know which one is which, obviously, but I do like that, because I think we've had people come through our network that need a harm reduction would not work for them. That they've tried, unsuccessfully tried a harm reduction model and can use a little bit more structure. We've seen people very motivated by faith-based organizations, and we've seen some people that are not motivated by that at all. So I for one like that. SUPR allows for a big enough pool for everybody to kind of create a recovery home that might work for a specific subset of people that need it.
No, I agree, Jim. I know that our leadership with SUPR is really pro, there's multiple pathways. Meet people where they are, and it's up to us to come to them when they're ready for help. So it's a very refreshing organization to work for. It's a department, I really enjoy it in that sense. Our leadership here is great with SUPR, in my opinion.
I thought that Vanna, did you have a question?
No, just a comment. So to kind of piggyback on what Margarita said earlier, and I think there's this misconception that recovery home operators don't want to deal with people who are using, and that is not the case. I've said this once before. This is primarily about capacity. So like Margarita said, we don't have the medical staff, and we're doing people an injustice if we allow them to come into the home and we can't take care of them properly or support them properly, if that makes sense. So it's not that we don't want them, we don't have the capacity to do it. Okay, so then the other piece to that is with these with people who have medically complex issues and things like that. It's being able to support them and understand. So we're one of the larger recovery homes. So we have staff, we have the facility. If you're thinking about some of the other recovery homes that may have operator themselves running the facility, being able to kind of assess and take care of people with medically complex issues, mental health issues, medications, it's a lot. And so we're doing the best we can with what we have. And again, I have to stress, it's not that we don't want them. Oh no, we can't take those people. It's that we don't have the capacity to do so. So I just want to make that clear.
With that comment, do we have a lot of housing for people who have more complex issues? Is that really the problem or the issue? Is that
Yeah,
Or
I'll
complexity?
comment on that really quickly because I've had challenges. We had taken someone, and as I said, we assess each person individually, right? And so there are always exceptions. It's not strictly, we don't take anybody who, has been using recently. It depends on the individual situation. That is also true for people with medical issues, right? So we took a resident who had some medical issues, and we found that she was going to the hospital every week to the emergency room. And again, we assess that we're not doing her, we're not helping her because she needs to get these medical issues addressed, right? And so I went on this search for housing for her. Nursing homes, places that had medical staff that dealt with, she had some mental health challenges as well. And so there was no place. I was literally on the phone for weeks, and we held her as long as we could. And what we ended up doing, she had a relapse, so we referred her to a treatment facility, and they were able to get her placed, maybe because they have more resources, more connections, more partnerships. I don't know, but that is a challenge because us, a recovery home operator, trying to navigate the system for housing someone. There was one place that she qualified with a mental health diagnosis, qualified with her medical condition, but did not qualify because she had substance use disorder. So it is really a challenge. And I think that's the issue. There are other types of housing that is needed in order to house people, but trying to fit people into the round hole of a recovery home when it's a square peg, I think is kind of unfair. So, and we know the housing is needed. I totally agree 100%, but I don't know that the recovery home is the right place for all of those things. I have the saying, shoemaker, stick to thy last, like stick with what you do really well. And what recovery home operators do really well is recovery housing, as out 6509. That is my little piece.
Would that
Thank
be
you for that.
like a level 3.7, or I'm thinking like I'm not, I know there's the co-occurring disorder residences that would be, I guess, 3.5. Would 3.7 be if a person has a substance use condition and a co-occurring medical condition? Is that what we would call 3.7 in the ASAM level of care? I'm not, sorry for people that aren't needing to follow all of the levels of care with ASAM, but I'm just
I'll chime in, Tim. I just went to a 3.7 training.
okay.
It's not
Good.
recovery home based, it's residential.
Yeah, right.
Including like the on-site medical care with a nurse.
Yeah. So that would be, it's medical. It's substance use and medical. It's a residence. It's a residential program, not a recovery.
Yes.
I want to reiterate Sammy Shea, her name or her point in the chat box. She said Vanya. She said that's a great point, Vana. I think the medical respite shelter model can be great for some of those medically complex clients, except those programs are not inherently SUD or recovery focused. So it would be great in the future if we have a recovery plus medical respite shelter where these more complex medical patients could access recovery meetings and support services as part of their stay. And I think that's an incredible point. And I just want to hop on camera, even though I'm in the car, to say this to you all. Those type of ideas could really formulate and get some traction if you guys decide to write op-eds for the Chicago Sun-Times, which everyone on our task force has the ability to do, whether you come to our meetings all the time or not, because those are the type of ideas. Once upon a time, just like safe consumption sites and just like Narcan, started inside of a chat box on Zoom. So I really encourage you guys to work with me and our person who's working with us at Chicago Sun-Times to write about some of these things. And if you need help doing that, I'm available. But that is a serious idea, and the client complexity does make this such an interesting story. So happy to help anybody who wants to make that a piece. That's all, my 2 cents. And I appreciate your 2 cents, Anna. That's a great.
Yeah, and I think it's really important to identify that the level of care that people need can't be met in a recovery home, and maybe it is 3.7, and maybe it's something to promulgate. I don't know how many 3.7s we have in the state, Emily. Medical recovery residences, I guess is what we call them.
That is a number I don't know off the top of my head.
Yeah. I'm struggling to even think of even one in Chicago, if we even have one. Yeah.
Emily, is that something that you could get back to us on? I was really curious after going to that ASAM training if we had any in Illinois.
Yep.
Thank you.
And I guess the question is when it comes down to funding, that would take funding to start, right? And I don't know if how would an organization start that without some upfront funding from SUPR, from the Department of Public Health, that type of thing, right? So we never get, we have, Vanna's housing and Safe Havens housing, but we never get to another level where we are dealing with these more complex things because we're not even like saying, hey, this is so needed and we're going to provide funding for it. And and that's medical and substance use disorder. Was mental health included in that? Just curious.
Yeah, so I know that as far as the ASAM is concerned, that would be level 3.5, which is also going to be, a higher level of care and costs more because it's going to include, treating people with more severe courses of mental illness and substance use disorder. It'd be 3.5.
Yeah, Sammy referred to in the chat Boulevard, and I just looked on their website quickly, and I I don't think they have they deal with substance use disorder. I didn't see it. It's medical respite. It appears to be medical respite, and I don't see anything.
Yeah, it is medical respite. We work at PCC. We work fairly closely with the Boulevard. It is medical respite, and it's like harm reduction focused. So folks who are using or who have a substance use history can go there, but they have to. The primary referral reason has to be medical. So like we can't just refer people for substance use, but from what I've heard from that staff there, they're not really equipped to be like supporting the substance use needs per se. So I know they've had like a history of some overdoses happening on site. They don't necessarily have like recovery support services and meetings and some of those great things that recovery homes do offer for people who want to move forward in their recovery. So I feel like finding a way in the future to integrate those models so that you have the more complex medical needs being addressed, like Vanna said, having like the right type of facility and people to treat that, but then also having the recovery services built in that people really want to access in recovery homes, I feel like could be a marriage that we want to look at in the future.
And Mado deals with mental health, right? It's residential mental health, but they have a very limited number of spots for people who have substance use disorder. And if they have overdose, once they do their assessment, and this is my experience, once they do the assessment, if somebody has had an overdose recently, I think it's like within the last year, they will not take them, or they didn't take this particular client because of the risk of overdose, which speaks to what Sammy just said. Their focus is mental health and not substance use disorder. So they don't have the capacity to support those people with SUD. So again, it's all these little pieces that need to be brought together in some kind of way.
Any other comments or questions for Emily or the group or comments?
I put a question for Emily in the chat about, I didn't, in the rule, is there any guidance listed on how recovery home operators could use or not use urine drug screens? Because I do think it's a limiting factor for admissions after you sort of explained the rule, as well as keeping people in the recovery home if they had a recurrence outside of the four walls.
No, that's going to be up to the recovery home to determine. So you're going to have, you know, the procedures laid out on how you are going to handle those situations if someone does use, or if it say they do have a positive test, how you handle that. That's SUPR does not determine that. We leave that up to the recovery home.
But I just want to say that most recovery homes that have those situations are going to still follow the guidelines of our DASA contract that go with the 2060, right? Because we know that somebody that could use, we're fortunate enough that all of our recovery homes, we have treatment with it on site. So of course they're going to see the SUD counselor, and the SUD counselor is going to evaluate that situation to be able to determine if that person still meets that level of care or needs a higher level of care. So once again, it's the risk factor of somebody, if they fall back into dimension 1, are they going to go through withdrawals, symptoms and stuff while they're there? Not necessarily the use. It's about, following that structure and guidelines that's already been given to us through the 2060. So I think most, and stuff. And one of the drug screen things and stuff, if I'm understanding and stuff, it is a risk factor to make sure that we're able to record people, individuals who may have a lapse or a relapse moment during their stay, because of that risk factor. So that's why drug screens are done at admission, not that they'll hold them against an individual being able to enter the program, but we have to know, like, what's in your system. Is there anything we need to send you out for a medical clearance that couldn't cause death? So a lot of risk factors are during that time and stuff. And we're able to record with ongoing sobriety, right? With routine drug screenings, we're able to say somebody within their 30 days of continued stay has maintained their sobriety, and their 60-day and their 90-day and so on, to be able to say also too that they've maintained their sobriety.
Thank you for sharing that. We just had the privilege of hearing from a lot of peers at ASAM, and a lot of them talked about how those decisions about their urine drug screens were often not made by medical professionals, right, but by substance use counselors. So that's why I'm just sort of pushing back and questioning, is that the best decision for a counselor to make with the screen, or is that better made by a medical provider to determine kind of risk and weigh that decisional balance about whether they need a higher level of care or not? That's just something I've been kind of pondering and walked away with, because it weighed very heavily on me. And those voices in recovery, about how much it was hurtful when a non-medical provider would make a decision based on their level of care. I think we really have to re-examine that.
Yeah. Well, I can only just tell you that, first of all, most of the recovery homes don't have a medical facility individual on site, but we have a licensed individual that has been licensed to be able to determine people's levels of care. That's why you have a CADC. That's why you have LCSWs, do things like that, that they're licensed to be able to determine people's level of care. I mean, that's what the 2060 is based off for all CADCs. So medically, I mean, if that factor was even to become a rule and stuff, most recovery homes wouldn't be able to have a doctor on site who's going to be able to do that 24 hours a day, versus that you have a substance use counselor on site at that time. And some of us agencies work with laboratories that also are going to give you the actual what's in their system versus that you may have a false negative and stuff. Some of us work with laboratories to be able to determine that. And then we have a director, medical director, who reviews those drug screens if it's deemed something in there, and to determine if another medical treatment is needed. So there's different varieties of how the recovery homes are working.
I want to say really quick too that Safe Haven is different. So most recovery homes don't have treatment on site. I don't know how many do, but I know most of them don't. And so there are no counselors there. And our only option, if we do a drug screen, Phoenix doesn't do them on entry, right? But if you do a random or for cause and it comes back positive, our only option is to send them out, right? To Haymarket to get assessed, right? To Southwood to get assessed. And then we go from there because we don't have the capacity. There are no counselors, there's no medical staff, any of that.
Jim, I thought I saw your hand up. Oh, yeah.
Yeah, just to add a little bit to what Margarita, what you were saying too, like the other thing to consider too is with the lack of people willing to go into 30-day or longer residential treatment, oftentimes recovery homes, I think, have to guard against the misplacement of people who maybe need residential care, level 3 care, that are kind of being masked as a recovery home eligible resident. We have to be careful of that. We don't, you know, I feel like that's part of the shoemaker analogy that you were using earlier. I think that that's part of it, right? We have to make sure that the clients that are coming in are actually truly recovery ready and not, you know, masquerading as somebody who is and is maybe skipping other levels of care, mostly because what that does to the other residents who are in that abstinence maintenance, maintenance level stage of change. So that's another thing to consider. You know, I think anyway, is that we kind of do our admission procedures, at least we do at Maryville, in a way to try and make sure the right clients show up and are given access to these opportunities. Housing being what it is, treatment, insurance being what it is. Sometimes people are not eligible to go to level 3 recovery-based treatment centers for reasons outside of their willingness too. So it's something to consider also.
Yeah, I think it's really important to note, as you're saying, Jim, and everyone's sharing, that the level 3 medical, mental health, co-occurring type residential programs with substance use, we just don't have them. You know, I mean, there's a few that have been referenced in the Boulevard, but or more respite shelter places, which are so important and so needed. But I think, you know, with the exception of the Gateway residential program, the Independence program, Thresholds has a residential 3.5, but actually, I don't know that it's even super funded though. I don't think it is super funded. So there really aren't any other than that Gateway one that I can think of that are in Chicago that are for mental illness. And as far as medical goes, Emily will get back to us on what's out there, but I don't know that we have one.
Sorry to interrupt. I just pulled the Chimera report for that. We have
good.
3. We have 3.7s. We have one in Champaign. Go ahead.
Okay, good. No, that's great. Champaign.
One in Champaign, Rosecrans. We have Seed in Charleston, Illinois, so Coles County, and then the Loretto Hospital. Oh, the Loretto and Cook County.
Oh,
that's what we have. We're at 3.7 licensure.
Very good. So that's good to know. Loretto has one.
Yeah.
Okay. Yeah. This has been great. I want to be respectful of the time. It's now 12. Really appreciate everyone's input and participation. Emily, thank you for presenting today. And I take it if anyone has any follow-up questions, they could get back to you. They could, you know, we can help facilitate any kind of further conversation as well. And really appreciate everyone's input and being part of this today. Thank you.
Thank you, guys. Have a
Thank
good
you.
afternoon.
Yeah. Take care, everyone.
Tim,
Have a
Tim,
good
can I
day,
get,
everyone.
I don't
Go
know
ahead,
if I
I'm
could,
staying in.
if I could, be invited, to the next one.
Absolutely,
Is that all
Jim.
right?
Of course, yeah.
I'm usually trying to
We're
talk
looking for
myself
your
out of
information in
meetings.
the chat box, Jim, and we'll make sure of that.
Yeah.
Okay.
Thanks,
Yeah,
Jim.
I've already,
Great to have you here.
all right, great. Thank you, guys.
Great. You take care. Okay. Thanks, everyone.
Great meeting, Tim. It's getting better and better.
Thanks for being here,
See
V.
ya.
Thank
Have
you.
a good one.
Take care. Bye.
Thank you so much.
Thank you, Emily. Appreciate it. All
Yeah,
right.
if you want to, you can always send an invite, and if I can make it, your meeting, this was great. So
Very good. All right. Have a wonderful evening, afternoon.